Hi everyone, and welcome to our module on atrial fibrillation and Flutter. Let's start by talking about atrial fibrillation. Atrial fibrillation is one of the most common cardiac arrhythmias. You will definitely see this on your clinical rotations frequently. It causes a pulse that is irregularly irregular. This is the classic description of the pulse in atrial fibrillation, and you should recognize it for your board exams. The symptoms, as we'll talk about in a minute, are variable, but atrial fibrillation can cause palpitations, fatigue, and sometimes dyspnea, and the diagnosis is always made by EKG. If you look at these two tracings on the screen here, the bottom tracing is an example of normal sinus rhythm. There are P waves followed by QRS complexes occurring at regular intervals. On the top is an example of atrial fibrillation. There are no P waves, and the baseline just has this undulating wiggle worm sort of appearance. And the QRS complexes are occurring at irregular intervals. Some are close together like this, some are further apart. There's no regularity to it. And this is the classic way that atrial fibrillation looks on the ECG. Here's another example in a full 12-lead ECG. If you look carefully, you will see that some of these QRS complexes are further apart, like these here. Some are a bit closer together, like these two here. There are no clear P waves. Don't be confused by the baseline sort of waving up and down. Those don't represent P waves. That's just a shaky baseline that commonly occurs in atrial fibrillation. And here's another example where the atrial fibrillation is causing a tachycardia. We often refer to this as atrial fibrillation with RVR, and what RVR means is rapid ventricular response. If you look carefully, there are no P waves. Some QRS complexes are close together like these two, some are further apart like these two. The QRS complexes are occurring in an irregular pattern, and there are no underlying P waves. Classic example of atrial fibrillation on an ECG. There's some terminology around atrial fibrillation that you should know. Paroxysmal atrial fibrillation means atrial fibrillation that comes and goes with spontaneous conversion back to sinus rhythm, and we'll talk more about spontaneous conversion later in this video. Persistent atrial fibrillation is atrial fibrillation that lasts for days and weeks and often requires a procedure called a cardioversion to restore sinus rhythm. And then finally, permanent atrial fibrillation is atrial fibrillation that never goes away. Atrial fibrillation has a wide spectrum of symptoms. Many patients with atrial fibrillation, especially older patients, are asymptomatic, and in many cases these patients have a slower heart rate while they're in atrial fibrillation. Part of what causes the symptoms in AFib is the rapid heart rate, so patients who develop AFib with a slower heart rate tend to be less symptomatic. On the other end of the spectrum, there are patients who have palpitations, dyspnea, fatigue. Some of my patients feel very unwell when they're in AFib. They know exactly when their heart has flipped into AFib. And most of these patients have a faster heart rate, usually over 100 beats per minute, sometimes up to 150 or 160, and it's that fast heart rate that drives many of the symptoms of AFib. If you have a patient with atrial fibrillation who has a rapid ventricular response and a heart rate in the 150s or 160s, if you leave that untreated, that patient will eventually develop a cardiomyopathy, and it's important for you to know this for your board exams. After several weeks in AFib with a fast heart rate, patients develop what's known as a tachycardia-induced cardiomyopathy. Basically, the myocardium fatigues and the patient's left ventricular ejection fraction will fall, and they can even develop signs and symptoms of systolic heart failure. So this is one of the main reasons that even if patients are asymptomatic, we don't allow them to remain in AFib with rapid ventricular response. That's because we want to avoid having that patient develop a cardiomyopathy. Also, if patients do develop a cardiomyopathy from rapid AFib, that cardiomyopathy is usually completely reversible if you can make the AFib go away and restore sinus rhythm. This is a transesophageal echocardiogram of a patient in atrial fibrillation, and this structure here that I'm circling with my pen is the left atrial appendage. It's a very small outpouching of the left atrium, and that portion of the left atrium has the slowest blood flow, and the blood flow gets even slower when patients have AFib, and that can lead to formation of a thrombus. And what you're seeing here is a large thrombus in the left atrial appendage of a patient with atrial fibrillation. This is the feared outcome of AFib. If patients are not anticoagulated, they can form a thrombus in their left atrial appendage, and a piece of that thrombus can break off and go to the brain, and that will cause a stroke. So in order to avoid strokes, we always anticoagulate patients in atrial fibrillation, and we'll talk more about that in a minute. So I mentioned that pieces of those clots can go to the brain and cause a stroke. They can also go to other places. Sometimes they travel to the gut and can cause mesenteric ischemia. Sometimes they travel to the spleen. And when CAT scans are done to the abdomen of patients with AFib, you will sometimes see splenic infarcts. The major risk factor for atrial fibrillation is age. AFib occurs in about 10% of patients in their 80s, and it occurs in less than 1% of patients under 55. Most of my patients I take care of with AFib are in their 70s, 80s, or 90s. It's more common in women, and it is often associated with hypertension or coronary artery disease. These two conditions, which are very common, are often present in patients who have atrial fibrillation. In addition, always remember that anything that stretches the atria can cause atrial fibrillation. So patients who have heart failure and have high pressures in their left atrium will have the walls of the left atrium become stretched over time, and that often leads to AFib. So AFib is very common in patients with heart failure. Same is true of patients with valvular disease. If patients have mitral stenosis or mitral regurgitation, their left atrium can become dilated, and that also predisposes to AFib. And if you understand this, it's very easy to remember that the most important initial test after you have diagnosed AFib is usually an echocardiogram. That's because it lets you visualize the left ventricle and the other chambers of the heart. You can see if there's evidence of cardiomyopathy or heart failure or valvular disease that might be contributing to the atrial fibrillation. Patients who have hyperthyroidism commonly develop atrial fibrillation. This type of atrial fibrillation associated with thyroid disease is almost always reversible. It will go away once you treat the thyroid disease. And it's very important to identify patients who have hyperthyroidism, because when you try to treat atrial fibrillation in patients with hyperthyroidism, the usual therapies, which we'll talk about later, are less effective until you get the levels of thyroid hormone down. So for this reason, a key diagnostic test in any patient with new onset atrial fibrillation is a TSH level. Basically, anyone who has new atrial fibrillation almost always gets an echocardiogram, like I told you on the last slide, and also a TSH to screen for thyroid disease. Some patients with atrial fibrillation have a trigger that causes the arrhythmia to occur. Now, for many patients, there's no trigger identified, but there are some where a trigger is identified, and you should be aware of these. A classic one is binge drinking. This is sometimes called the holiday heart. There are certain patients of mine who anytime they go out and have more than one glass of wine, they go into AFib. And once you figure that out, you have to caution them to avoid alcohol to avoid going into AFib. Another classic trigger that you will see over and over again on your hospital rotations is increased catecholamines. So patients who have systemic infections or who are recovering from surgery or have pain after recovering from surgery, all these patients have high levels of catecholamines, and that often triggers atrial fibrillation. So many patients in the hospital go into atrial fibrillation. The atrial fibrillation almost always goes away once these underlying conditions have resolved. Okay, so now that we've talked about the clinical presentation of atrial fibrillation and the diagnosis, let's talk about how to treat atrial fibrillation. And treatments for atrial fibrillation fall under one of three categories. The first category is medications used for rate control. These are designed to control the heart rate and keep it from being too fast. Ideally, we try to keep patients with atrial fibrillation under 110 beats per minute for heart rate. Second treatment category is rhythm control. There are meds used to treat atrial fibrillation, with the goal of the medication being to restore sinus rhythm and get the patient out of atrial fibrillation. And then finally, there are drugs used for anticoagulation to limit the risk of stroke. So we'll go through each of these categories one at a time. Shown on this slide is an example of what medications used for rate control can do in patients with atrial fibrillation. On the left side of the screen is an example of rapid atrial fibrillation. Medications used for rate control will allow the atrial fibrillation to persist, but will slow down the heart rate. And often this is very effective for making patients feel better. As I told you before, many of the symptoms of AFib come from the fast heart rate. So if you simply slow the heart rate down, patients often feel better. Also, like I told you before, fast heart rates, if allowed to continue for several weeks, will lead to cardiomyopathy. So by slowing the heart rate down, you prevent the development of a tachycardia-induced cardiomyopathy. And the types of drugs used for rate control generally fall under three categories: beta blockers, calcium channel blockers, and digoxin. All of these groups of medications slow conduction in the AV node, and that's the idea here. In atrial fibrillation, there are millions of depolarizations of the atrial myocytes per second, and what's happening when the heart rate is fast is that too many of those depolarizations are making it through the AV node to cause a QRS complex and a ventricular contraction. So if you slow conduction in the AV node, then the AFib will go on, but the heart rate will get slower, and that's what these groups of drugs all achieve. So as I just mentioned, all of the drugs used for rate control slow AV nodal conduction. Beta blockers used for rate control are usually beta-1 selective agents like metoprolol and atenolol. These agents target the beta-1 receptors found in the AV node. One special note, and this is super high yield for board exams, in patients who are hyperthyroid and also have atrial fibrillation, the drug of choice is propranolol, and I've written that on this slide here to remind you of that. Propranolol is an old beta blocker that we don't use much anymore in the modern era, but in addition to being a beta blocker that slows conduction through the AV node, it also minimizes many of the symptoms of hyperthyroidism, so it's the ideal drug in hyperthyroid patients with atrial fibrillation. Calcium channel blockers that are used are the calcium channel blockers that work on the heart, like verapamil and diltiazem. And then finally, digoxin can be used because it increases parasympathetic tone to the heart, and that slows conduction in the AV node. Years ago, digoxin was often used for AFib rate control. It's rarely used in the modern era. We usually use either beta blockers or calcium channel blockers. Shown on this slide is an example of what rhythm control does in atrial fibrillation. So once again, on the left side of the screen, we have rapid atrial fibrillation, and then something is done to cause cardioversion, which is the term we use to mean reversion of the AFib back to sinus rhythm, and that's sinus rhythm on the right side of the screen. We have P waves and QRS complexes after each P wave. So the goal of rhythm control is to somehow achieve cardioversion and try to keep the patient in sinus rhythm. And as you can imagine, rhythm control is often used in patients who have symptoms even after we slow their heart rate down. Those are the patients who really need to be in sinus rhythm to feel well. So there's a couple of ways to achieve cardioversion in atrial fibrillation. The first way is electrical. In electrical cardioversion, you deliver a synchronized shock using a defibrillator. This is a picture of a defibrillator on the screen here. A synchronized shock is a shock delivered at the same time as a QRS complex, and we always synchronize the shock to the QRS complex in patients with supraventricular tachycardias like atrial fibrillation. The reason we do this is because if a shock is administered on the T wave, it can potentially cause the rhythm to degenerate into ventricular fibrillation. Electrical cardioversion always requires anesthesia because it's very painful for the patient if they are awake. You deliver an electrical shock to the chest, all the myocytes depolarize, and usually the SA node is the first structure in the heart to begin repolarizing and depolarizing, and thus sinus rhythm is restored. And this works about 80% of the time or so. You deliver an electrical shock and patients convert to sinus rhythm. Second option for cardioversion is chemical. We can use antiarrhythmic drugs to cause the patient to convert from AFib to sinus rhythm. Usually the drug that is used is ibutilide. It's a class 3 antiarrhythmic drug that is relatively short acting. And in the modern era, we don't do this very often because after you administer ibutilide, you have to monitor the patient for drug toxicity. With an electrical cardioversion, as soon as the procedure is over, the patient can wake up from anesthesia and go home. And then the last type of cardioversion is spontaneous. Many patients who have AFib will flip back into sinus rhythm after a few hours or days. Shown on the screen is an ECG tracing. The patient has AFib over here on the left side, and then the patient spontaneously converts, develops a P wave, and goes back into sinus rhythm. And this often happens to patients in the hospital on telemetry. If they have AFib triggered by an infection, as the infection resolves, they will spontaneously convert back to sinus rhythm, and no electrical or chemical cardioversion is required. Whenever a patient cardioverts from AFib to sinus rhythm, there is some risk of stroke. So anytime we're going to either administer a drug or use an electrical defibrillator to cardiovert someone, we have to be mindful of the fact that we could cause a stroke when we convert the patient back to sinus rhythm. There are very good studies that show that it requires 48 hours in atrial fibrillation for a thrombus to form in the left atrial appendage. For this reason, if someone comes in with AFib and you're sure that the symptoms and the AFib have been ongoing for less than 48 hours, you can perform a cardioversion immediately. If the symptoms have been ongoing for more than 48 hours, or if you're not sure how long they've been going on for, then you can't cardiovert immediately. You either need to administer anticoagulation for 3 weeks and then perform cardioversion, or you need to do a transesophageal echocardiogram to image the left atrial appendage, just like I showed you earlier, and once you exclude that a thrombus is present, then you can safely perform cardioversion. And then finally, an exception to all these rules is a patient who develops new onset atrial fibrillation and develops hypotension and shock. This is very rare, but if this does occur, you immediately perform a cardioversion no matter the risk of stroke. This often comes up in board exams. It's uncommon in real practice, but patients can go into very rapid atrial fibrillation and develop hypotension, and the treatment is always then to shock the patient and revert them to sinus rhythm no matter the risk of stroke. So when we choose a rhythm control strategy and we want to keep a patient in sinus rhythm, we often administer an antiarrhythmic medication around the time of cardioversion. The reason is that when you cardiovert a patient, either with electricity or with a drug like ibutilide, they may go into sinus rhythm, but they may go back into AFib shortly thereafter. If you treat them first with an antiarrhythmic drug, it makes it less likely that the patient will revert to atrial fibrillation. This is generally a high-level cardiology thing. You don't need to know a lot about this for your board exams, but you should be aware of some of the drugs we use for rhythm control. Class 1 drugs like flecainide and propafenone can be used in patients who have structurally normal hearts. In other words, no history of cardiomyopathy or valvular disease. Class 3 drugs like amiodarone, sotalol, and diphenylide can be used in patients who have structural heart disease. And you should be aware that many years ago there was a famous cardiology trial called the AFFIRM trial. And in this trial, patients with atrial fibrillation were randomized to either a rate control strategy or a rhythm control strategy. And the trial found that there was no mortality difference whether the patient stayed in AFib with a rate control strategy or was maintained in sinus rhythm with a rhythm control strategy. And for that reason, using these drugs, which carry a lot of toxicity to maintain sinus rhythm, is something we only do in very select patients. Now that we've talked about rate control and rhythm control, let's talk about the final element of treatment of atrial fibrillation, and that is stroke prevention through anticoagulation. As we saw earlier, patients with AFib can form a blood clot, so to prevent this, we administer drugs that lower the risk of a clot forming and causing a stroke. Generally, patients with AFib are either prescribed an anticoagulant, which is one of these drugs on the left side of the screen, or aspirin. And in a minute, we'll talk about how you decide which type of drug to give to the patient. In terms of anticoagulants, there are three options: warfarin, rivaroxaban and apixaban, and dabigatran. Let's talk about each of them one at a time. Warfarin is a vitamin K antagonist. It blocks the formation of clotting factors in the liver. The problem with warfarin is it requires regular blood testing to measure the INR, and that's a nuisance for patients. Usually when you treat a patient with AFib for stroke prevention with warfarin, you titrate the dose to achieve an INR of 2 to 3, and you have to check it frequently because the INR can go up and down depending on the patient's diet. Nowadays we rarely use warfarin, and that's because these two groups of drugs are available. Rivaroxaban and apixaban are factor Xa inhibitors, and dabigatran is a direct thrombin inhibitor. All of these drugs are oral. You take them either once or twice per day, and the dosing is standard and doesn't have to be checked or titrated based on the INR. So in the modern era, we rarely use warfarin. We usually use one of these drugs as anticoagulants. In some patients who are at very low risk of stroke, and we'll talk more about this in a minute, instead of one of these three anticoagulants, you can use aspirin. In general, it's less effective for stroke prevention, so we only use this if the risk of stroke is very low. The good thing about aspirin, and the reason we like to use it when we can, is that there's less risk of bleeding with aspirin compared to any of the anticoagulants on the left side of the screen. In a minute, we'll talk about how to select an anticoagulant drug for an individual patient, but I want to mention here that anticoagulation must be administered to patients with AFib, no matter whether you adopt a rhythm or rate control strategy. Studies have shown that whether atrial fibrillation persists or whether sinus rhythm is restored, the stroke risk remains high in all patients who have a history of atrial fibrillation. Therefore, whether you're adopting rate control or rhythm control, the stroke risk is still going to be elevated and you must administer anticoagulation. So in order to determine the appropriate regimen to reduce the risk of stroke in patients who have atrial fibrillation, you first need to determine the patient's stroke risk. And this is done using the CHADS-VAS score. The CHADS-VAS score is a point system. Patients with a history of heart failure get a point. The same is true for patients with a history of hypertension or diabetes. History of a stroke is 2 points, female gender is 1 point, age 65 to 75 is 1 point, and age over 75 is 2 points, and vascular disease is 1 point. This would be things like peripheral vascular disease or carotid artery disease. So you total up the score for your particular patient, and if the score is 2 or greater, that patient should be treated with warfarin or one of the other anticoagulant drugs. If the score is 0 to 1, the patient does not require anticoagulation. There are two options for what to do in patients with a CHADS-VAS score of 0 to 1. We used to give all these patients aspirin, although newer data has called aspirin into question, showing that it may not be effective, so many patients simply require no therapy whatsoever. But for anyone with a score of 0 to 1, it's either going to be aspirin or no therapy. Anticoagulants are only going to be given to patients who have a score of 2 or greater. So here's a summary of what you need to know about atrial fibrillation for your board exams. If you understand everything on this slide, you can answer just about any question on AFib. So if a patient has new onset atrial fibrillation, the first thing to know is that if they are unstable, they need an emergent cardioversion. If the patient is stable, the two important tests are an echocardiogram to rule out structural heart disease and valve disease, and a TSH measurement to screen for thyroid disease. At this point, you can decide whether you want to do rate control or rhythm control. If you're going to employ a rate control strategy, beta blockers, calcium channel blockers, and digoxin are the drugs that are used. If you're going to employ a rhythm control strategy, you need some method of cardioversion back to sinus rhythm, and you may add antiarrhythmic drugs to keep the patient in normal sinus rhythm. And then finally, no matter which strategy you select, rate control or rhythm control, you must prescribe appropriate anticoagulation with aspirin, warfarin, or other drugs based on the CHADS-VAS score. There is a surgical procedure that can be used in patients who have refractory atrial fibrillation. This is atrial fibrillation usually that's symptomatic and continues to recur despite medication. The procedure is called a pulmonary vein isolation. To understand this, let's look at this drawing of the heart here. This is the left ventricle and this is the left atrium here. And there are 4 pulmonary veins, usually 4, that drain blood into the left atrium from the lungs. It turns out that many cases of AFib are initiated by electrical activity in these pulmonary veins. So if you can electrically isolate the pulmonary veins, then AFib will not occur. What is done is a catheter is used to burn a circle around the pulmonary veins, and this prevents the transmission of electrical activity from the pulmonary veins to the left atrium. And for many people, that reduces the burden of atrial fibrillation, so they have fewer or no episodes of atrial fibrillation. I'll finish this video by talking about atrial flutter, which shares many similarities to atrial fibrillation. If you look at this ECG on the screen, this is an example of atrial flutter. The classic finding is the sawtooth pattern of the baseline. So this is the sawtooth pattern here. It's very easy to recognize. It looks like a sawtooth going up and down. You can see it in all the leads. It's present in 2 here. It's present in V1. It's present in AVF. It's all over the place on the ECG. Atrial flutter is very similar to atrial fibrillation in that it tends to be episodic. It will occur and then potentially go away and then come back again. The symptoms are generally the same as atrial fibrillation, and many patients are asymptomatic, just like many patients with AFib are asymptomatic. When symptoms do occur, they're similar to AFib, things like palpitations, dyspnea, and fatigue. The treatment is also generally the same as the treatment for atrial fibrillation. You can adopt a rate or rhythm control strategy. The same rate-slowing drugs used for atrial fibrillation work for atrial flutter. The same methods of cardioversion used for atrial fibrillation work for atrial flutter. And you administer anticoagulation based on the CHADS-VAS stroke risk in patients with atrial flutter, the same way you do for atrial fibrillation. Just like there is an electrical surgical procedure for atrial fibrillation, there is also a surgical procedure for atrial flutter. It's called atrial flutter ablation. It works similar to the AFib pulmonary vein isolation, but the anatomy is different. In atrial flutter, the pulmonary veins are not the important structure. The important structure is usually the right atrium. In atrial flutter, there is usually a circuit of electricity going around and around in the right atrium. So what can be done is a catheter is used to burn and kill basically a line of myocytes like this through the right atrium. This carries no important consequences for the overall function of the right atrium. But what it does do is it prevents this electrical circuit from going around the right atrium because there's a line down the middle of it that will not conduct electricity. And this basically prevents the formation of atrial flutter. It's a very effective procedure, and it's usually done in people who have recurrences of atrial flutter after medical therapy. And that concludes our module on atrial fibrillation and flutter.